Hello, welcome again to Miami Community Health. I'm Dr. Anthony Gonzalez here for another important health topic. You know, here at Miami Community Health, we are always trying to help you live longer. And how do you live longer? You live longer by taking care of yourself. And one of the very important organs that you have to take care of, the ticker. The heart. You have to take care of the heart. And obviously the heart, if the heart's not working well, you're going to have a lot of problems. And we know heart disease, big killer in the U.S. And so we're going to learn today a little bit about the heart. We're going to learn about heart disease. And what better to learn about heart disease than have a cardiologist with us. So we have a Baptist Health cardiologist with us, Alex Toirac. Welcome.
Thanks for having me.
All righty. So Alex, tell us a little bit about yourself. You're a cardiologist. You take care of the heart, but it's more than just the heart, right?
Yeah, absolutely. I mean, it's a very complex organ system, I would say. The heart, connects, very closely related to the kidneys, the brain. We feel like, and, the arteries of the heart are the same as the arteries everywhere else. So you have disease in the heart arteries. We assume there's disease elsewhere. So it's a complex organ system that involves, every discipline and a lot of risk factors to make sure that you keep that heart nice and healthy. Yeah.
And it still is like the biggest killer in the U.S., right? Heart disease?
Still is. I mean, we're living longer and, traditional risk factors haven't really gone away and many actually have gone worse, as a society, as our country particularly. I think a lot of our, practices and habits of living have kind of worsened, been more unhealthier, and that's led to an increase in cardiovascular disease for sure.
All right, and the best way to treat heart disease is to never have heart disease. Is it possible to never have heart disease?
Yeah, it's possible. I mean, most of what I do, particularly, my practice is divided into two aspects. So, inpatient in the hospital, where I'm treating issues. People come in with chest pain, heart failure, arrhythmias, so they're already sick. Or not all terribly sick, but already have something going on. In the office, most of what I do is prevention. And absolutely, that's the most important aspect of preventing, cardiovascular disease in the future, preventing heart attacks, preventing strokes. It starts at an early age. I think we're finding out more and more that things as early as your teens to your 20s impact your heart, in your 60s, 70s, where we traditionally see these things come to light. So prevention is super important. I tell my young patients starting off, it starts at that age in your 30s. You may think you're healthy and, you don't have to worry about much, but in reality, controlling things like your blood pressure, your sugar levels, making sure you're active, exercising, that's all super important and goes a long way in your health down the road.
All right, so let's talk about prevention.
Sure.
So should somebody go see a cardiologist if they don't think they have a heart problem? Now, I go see my primary doctor, and he's fine. My blood pressure is good. He does an EKG on me. He says it looks good. I don't know what it looks like. I don't know how to read that. And should I be seeing a cardiologist?
A lot of what we do is overlapped with what our primary care providers do, and it depends on their level of comfort dealing with these issues. Obviously, if there's any level of discomfort or any uncertainty with the patient or the provider, always I urge to see a cardiologist, because that's all I do. It's just heart disease. Primary care providers have a lot to handle, to manage. And I think the key is identifying high-risk patients. Who's at high risk? Who needs to be, taking a really closer in-depth look at whether it's their cholesterol panel, whether it's their blood pressure, and really being more aggressive with managing those things. So I think not everyone has to see a cardiologist, but when it comes to someone who may be higher risk, whether it's a family history or already had an event, those are the ones where I think I'd urge to see a cardiologist sooner rather than later.
All right, and you'd already mentioned a little bit about prevention, the best way to prevent it. We said eating healthy, obviously no obesity, right?
Yeah.
Smoking.
Yeah.
What are the things that, will help us have a healthy heart?
Yeah, I mean, those are the big things. I mean, smoking that's so modifiable, right? You talk about modifiable risk factors, things we can control. We can't control genetics. What happens to your family, you can't control that. We can't control is, not using tobacco, our weight. I mean, we know the impact obesity has on every condition, but particularly heart disease. Healthy diet, and I think diet is complex. Seems like every other day there's a new fad diet, and either carbs are the enemies, the proteins the enemies. I mean, I keep it simple for patients. I mean, the best diet is one that is consistent, one that you can maintain yourself. So I don't really buy into any of these fad extreme diets. Well-balanced diets, healthy fats, a good mixture of protein and carbs. That's usually what I recommend. And exercise. Yes. I mean, we know whether there's exercise, we know the benefits already, and it's probably underappreciated because of the benefits that exercise has, not only directly on the heart, but we're talking mental health. Just people feel better, and we know people who exercise, are active, just live longer, healthy lives. So that's huge. I tell my patients, get moving. No matter what your condition is, you can have the worst heart in the world or the healthiest heart in the world. Get moving, do exercise, and it's going to benefit you greatly.
All right, so I'm a young guy, I'm exercising, I'm not smoking, Doc. How do I know I may have a problem with my heart? What are some of the symptoms that you should worry out there that, hey, there's something happening with my heart?
Yeah, number one is, again, identifying if you're at high risk or not. You know, did your father have a heart attack in his 50s? Do you have a genetic disposition to high cholesterol, things like that? So we have routine, urge, definitely in your 30s, you start getting all this routine lab work, checking the cholesterol, checking your hemoglobin A1C, which is a marker of diabetes, checking your labs. So that's the first thing. So, getting going with the prevention aspect. And then I tell my patients, know your body. Everyone's different. Everyone will have different symptoms to different conditions. So just know it, whenever, if you feel something's off, don't hesitate to seek out help, because you really want to catch something early before it gets worse. So just know your body. That's the biggest thing I tell my patients.
And then are there certain pains or certain things you feel? Everybody, there was this big marketing for, I should buy this little sensor for my iPhone so I can see if I have some type of arrhythmia. Should I be buying that? What should I be doing?
Yeah, especially young patients, I'll get a lot of palpitations or my heart skipping a beat. Those are great tools, and we have a lot of great tools that weren't around 10, 15 years ago. I mean, iWatches, Apple Watches. You're talking the ProCardia, which is not ProCardia, but it's one of those devices where they're kind of ambulatory EKG monitors. I mean, those are helpful if you're having a lot of symptoms. There's a lot of good tools out there which can maybe help detect stuff. That, and also it helps me when a patient comes in with these symptoms and they have proof, look, this is what my rhythm was at that time. So that's really helpful. When it comes to chest pain, there are characteristic chest pains that we consider concerning. Anybody who's having a chest pressure, really any chest pain that happens with exertion, with working out, moving around, and gets better with rest, that's always concerning. We get a lot of anxiety and panic attacks. They do mimic heart attacks a lot. I don't want to diminish anxiety. I mean, it's a real thing, and especially the first time it happens, I think it's worth seeking an evaluation. And then once you start knowing yourself, okay, I get peace of mind. I know this is not a heart attack. Most people feel better afterwards. So peace of mind is very important. It's a lot of what I do for my young patients who are otherwise healthy. I'll do studies that are non-invasive, not dangerous, but even if I think there's low suspicion, but it gives them peace of mind and they often feel better.
All right. So when should I be going to the emergency room? I don't have heart disease. I don't have any heart problems. When should I be, hey, I got to go to the ER?
Yeah. So I think a big part of it depends on your communication with your, I'm hoping you have really good communication, and vice versa with your offices, your primary care or your cardiologist. And, it's often great that if you can reach out and they can get back to you soon. If they can't, obviously, if you're at all concerned, this is not something you want to mess around with. So especially if it's your first time experiencing these symptoms, I would urge you, any kind of chest pain that lasts for a significant amount of time, several hours, I would say just seek immediate attention, especially whether it's reaching out to your clinic, a provider, or just going to the ER. And after the first evaluation, to say it comes out benign or clean, or they do find something, now in the future what the symptoms are. You kind of recognize what is concerning for yourself. So everyone's a little bit different, but you don't want to miss it. So I would say chest pain, always be on high alert and seek immediate attention. Not necessarily the ER, but reach out to a medical provider, and they'll hopefully give you guidance whether or not they think you need to go to the ER or not.
All right. So I go to the ER. I had some chest pressure. What happens in the ER to find out if I'm having a heart attack? Let's go through it and educate our population about what they're doing over there.
Of course. So that's what I do a lot. So when I'm in the hospital, I do the hospital about half the month. I often get consults for chest pain. I go to, I first of all, I hear a story from my colleague, and then I go interview the patient. You get a detailed history of not only their symptoms, describe the chest pain, what's happening, but you also get a good idea of their history, medical history. So are they diabetic? And do they have high blood pressure? Then we have diagnostic tools that help us. And ultimately, these are what lead to diagnosis, our diagnosis. EKGs will tell you if you're having acute ischemic event or a heart attack. We have enzymes, laboratory testing called troponins, which will tell you, is the heart being damaged? And we have other tools as well. We have echocardiograms, which are ultrasounds of the heart, which tell us, is the heart being damaged? Whether are the walls not moving well? Is the heart weak? Are the valves, how do the valves look? And obviously vital signs are incredibly important. What's the blood pressure doing? What is the heart rate doing? And other lab work as well. How do the kidneys look? So it's a ton of testing, and we've gotten really good. We're really good now at this point at identifying who's having an event, meaning a heart attack, or who's not.
And really acting on somebody who's having a heart attack in a judicious amount of time is very important, right? Explain that to us. Explain that, that the practices have changed, that you have to act within a certain period of time to really have a great outcome.
Yeah, absolutely. I mean, they're just saying time is myocardium. So myocardium.
Oh, time is not money. It's time is
myocardium. Yeah. So myocardium is a heart muscle. So, during a heart attack, the muscle's lacking oxygen, lacking blood flow. And, the more time that happens with lack of blood flow, more damage that happens. So certainly catching it early is extremely important. And obviously we have tools, our interventionalists, have ways of opening up these arteries and providing blood flow back to that area. So it's extremely important. And in addition to just interventions, we have medications that help stabilize these plaques that we presume are what are blocking the arteries. So it's extremely important to act early, and hopefully the earlier act, we're hoping you're going to prevent damage to the heart.
And so you come in, you have a heart attack in the ER, you're in the ER, they say, yeah, doc says your EKG's abnormal, your troponins are high. What happens next to that person?
It all depends on the patient too, right? I mean, I think you want to have a structure, a framework for how to treat these things, but also you got to individualize your treatment to each patient. So a 45-year-old healthy kids at home wants everything done. Obviously, you offer them an intervention, and most likely, and that's really the only curative fix, and that's what they go with most of the time. But we have elderly and 90-year-old patients, and maybe are extremely frail at home, maybe aren't terribly active, and you're not really sure how much benefit they'll get from this versus there are risks. Any procedure has risks, and we're in the coronary arteries, we're in the heart, so there's always risk for procedure. So you individualize the options and treatment options for the patients, and ultimately you make a joint decision on what the best route is. For a heart attack, really our options are going to be a coronary angiography, which is a catheter where we go in there, we use contrast, we see what the arteries look like. And I tell patients there's kind of three outcomes. Number one, there's a blocked artery that's easy to fix and we think it's causing your symptoms. We put a stent right then and there. Usually we get very good results. Two, hopefully we don't find anything, or is there's an artery that's very tough to either get to with catheters or complex, and we take a step back, kind of think, amongst ourselves what the best option are. Or there's many blocked arteries, and that's when we involve our surgery colleagues and we discuss maybe surgical options. So that's what I always tell my patients are options before going for a heart catheterization. Now,
if I have had heart disease, I was that 45-year-old, I came in through the ER, I got a stent, I'm doing well, I survived the widowmaker, right? Yeah. The big artery that kills everybody. Can I reverse that disease? Can I get better?
That's a very common question. People ask me all the time. I have calcium, I have blockages. Can we just scoop that out? We don't really at this time, this point in time, we don't have the technology to really clean out those arteries fully. What our stents do is they really just move those blockages to the outside of the artery. So they open up the vessel without removing it completely. You move the stuff to the side, and that should allow blood flow appropriately to the heart muscle. What I tell patients is it's all about preventing it from getting worse. I mean, you want to prevent a 30% blockage from being 70% blockage, 80% blockage. You want your stents. I mean, your stents are a foreign material you're introducing to your body. Your body is meant to attack anything that's foreign into your, put into your body. So, preventing those stents can clog up, can be restenosed, and that's why afterwards there's medications you're going to have to take. And the prevention risk factors that we had to prevent this altogether are even more important. Now we're talking secondary prevention. So now you've had an event. Now it's even more prudent that we take care of your blood pressure, your diabetes, your cholesterol, make sure you're exercising. That's now it becomes increasingly important. Okay, I tell my patients, primary prevention patients, so someone who's never had an event, but they may have risk factors, I'm a little bit more lenient. Not people don't like medications. Which is fine. I don't push medications on people unless I really think they're very high risk. When we talk about secondary prevention, now you've had an event, a heart attack, a stroke. To me, there's no question. Now I'm going to be on you about taking these medications because we want to prevent a future episode.
Yeah, people don't like, I hear all this thing, people don't like some of these cholesterol lowering medications. And sometimes I get a call from a cardiologist calling me about a family member of mine who refuses to take the medication. And you need to convince your family member to take the, so people are like really against taking some of these medications.
Yeah, statins are the big ones. It's my daily battle in the office is convincing patients to take statins.
And okay, you explain to our audience, why is it so important to take those medications if you need them?
Well, the
outcomes are so.
One of the most tried and true, based off literature, evidence-based things in cardiology and medicine is reduction in cholesterol, particularly LDL, which is bad cholesterol, leads to future cardiovascular events. That's tried and true. So however you can get it done, get it done. I mean, if you can do it through diet and exercise, certainly that's awesome. Unfortunately, it's hard to do it. I mean, cholesterol is probably, is a huge part of genetics, and also it's diet too. And we've learned more and more that these levels we want to get our cholesterol down to are really tough to do naturally. And I always urge patients, a patient who's never had an event, always the first thing is diet, exercise, and we'll get it down as much as possible. Some people still can't get it done, and it can't get it down to those levels we want. And if we're talking about minimizing your risk of a future event, sometimes these medications are needed. And every medication has side effects. I don't push medications on people without telling them the truth. And there are some side effects. With statins, you'll get muscle pains. It's true. They're not dangerous. They go away when you stop the medication.
But you can't stop the medication unless you can get your medication.
We have tons of other options now for anti-cholesterol regimens. We have a ton of options now. Statins are their go-to because they've been around forever. They're very cheap, so they're very accessible, and the data is great for them. We have a lot of other options for people who can't tolerate statins. Okay, but yeah, the big thing is I think a lot of us are, they think we're just pushing medications. That's not the case. None of this stuff replaces exercise, healthy diets. None of this does, but it's a supplement. And, there's a reason why, despite being increasingly unhealthy as a country, we're still maintaining, it's kind of plateaued, but increasing life expectancy because these medications work.
Right. Yeah. So you're pushing a medication because you're trying to save their lives.
Yeah, of course.
That's all you're trying to do. You're trying to prevent the next cardiac event.
Yeah. And there's patients who aren't going to want to do it. And it's fine. I have plenty of my patients who don't take medications. We acknowledge it. Every day we have the conversation when I see them and we disagree, and I still follow them. I still see them, and I want to know they're not taking their medications. And, keep a closer eye on them when symptoms do occur that we need to be, act even quicker than maybe somebody who has less risk factors.
All right, so let's talk about that calcium score.
Yeah.
That CT calcium score that I guess everybody should be getting. I'm happy to report that I've had a 0 twice already.
That's awesome.
The only test I ever want to have a 0 in, but I've had a 0. So explain to people what this the test is so fast.
Yeah.
When they did that test on me, the tech goes, "We're done." I think it's like 3 minutes, and it's like nothing. And I said to the guy, "No, I want to do it again." He goes, "No, I can't do it again for you, Dr. Gonzalez." I said, "Because I don't feel like I got the test." Right?
Yeah.
But what is that test? And how important is that test?
Yeah, so to understand it, so coronary calcium, so plaque, which is mostly made of cholesterol, builds up in and around the arteries and really in any vessels, but we care about the heart arteries. And over time, it calcifies. Calcium, it's scary. It's not necessarily a bad thing. It's stable. It's hard. It doesn't move. But we know we can measure calcium non-invasively through a CT scan. And it's a very quick study. And we know studies have shown that the higher the calcium score, it's predictive of higher future cardiovascular events. So what I think it's best used for is a patient who is healthy, has maybe some mildly elevated cholesterol levels, maybe a little elevated blood pressure, but otherwise healthy, has never had an event, not on really any medications. They're 40. They low to intermediate risk, I would say, in the future of heart events. Doc, I don't know if I want to take a medication. I don't know what I should do. And I think this is a good tiebreaker. I think people see, look, you have already evidence of coronary artery disease. And once they see that, because when you feel great, it's hard to wrap your mind around.
Somebody,
so that's what I think it's best for.
Okay.
I think most of us think it's best for. So
it's not for those that already have heart disease.
No, actually,
it's only a screener.
It's useless in a patient who's had a stent before, someone who has known, someone who's already going to be on these medications regardless. It's not very useful.
Yeah, it's only to know if you do have disease.
Yeah, exactly. And this test, yeah, exactly. So it's more of it's a risk stratification tool.
Okay. All right. So obviously, you said at the beginning, obesity, the link of obesity to heart disease, and how being obese impacts so many things in our life, and how it impacts the heart. I always say some of my best referrals are cardiologists who are sending me people for bariatric surgery. And of course, another hot topic is Ozempic and weight loss medications. Talk to us about how the importance of Ozempic can prevent heart attacks.
Yeah. So these it's a group of medications, the GLP-1 agonists. The most popular one, Ozempic. You may have heard of Mounjaro, Wegovy. So these group of medications, initially were diabetes medications, and there's a lot of overlap: diabetes, obesity, cardiovascular disease. But patients were getting treated for diabetes, and what they noticed was they were losing a lot of weight, and they also noticed that they were having less cardiovascular events. Which it makes sense, right? It's very intuitive. So now a lot of these medications actually have, when traditionally they were only indicated for people with diabetes, actually now there's cardiovascular indications. So anybody who's had a cardiovascular event, a heart attack, a stroke, peripheral artery disease, there's actually a group, some of these medications are now approved for just that indication in association with obesity. And I think with time goes on, they'll all have the indication. It's just a matter of, getting the studies down and whatnot. So, and I think it makes sense. And, the argument is always, you're always going to get this as, but, this is the easy way out. People are now using medications to lose weight, and I agree. I tell my patients, an obese patient, I always prefer, and this doesn't substitute you from changing your lifestyle. You need, and the same with you, right? I mean, you guys want to see someone put efforts in before you actually undergo surgery.
Yeah.
So I'm the same way. With these medications, I tell them, listen, this is not a replacement for healthy lifestyle modifications. You need to start exercising. You need to eat healthier. In fact, with these medications, you're at risk for losing muscle mass. So you have to work out. If you're not, you're going to just lose all your muscle, and you're not going to like the way you look either. So for me, I tell people, and for now, they seem like pretty safe medications. I mean, there's some early, GI symptoms, things like that, but they seem pretty healthy. long term, will we find out if there's more side effects? Potentially, I'm not sure. But what we do know is that obesity has a lot of long term side effects or issues. So you're kind of weighing, the pros and cons. And to me, I think the benefits right now outweigh, the negatives. Obviously, this is not replacing lifestyle interventions, but it's a good tool. And sometimes people just need a head start, a little push. And
well, at the end of the day, all we're trying to do is just decrease the heart attack, which is going to kill the patient. Obesity is not going to kill you. What's going to kill you is the diseases that obesity causes. Of
course.
So the take-home message is, if you're obese and you have heart disease, now you can get a GLP-1, an Ozempic, or Wegovy, whatever one that's covered, and you can lose the weight, which will decrease your chance of a heart attack and make you live longer.
Yeah, it'll decrease.
That's all we want, is for you to live longer.
Not just heart attacks. I mean, diabetes. It'll decrease the risk of stroke, decrease the risk of atrial fibrillation, of tons of things. I mean, we've been doing bariatric surgery forever. The outcomes have been great. Now we have a non-invasive way of doing it, and I think we use both approaches. And the goal is just to reduce,
any which way we can get you to lose the weight and decrease the morbidity and make you live longer.
Decrease mortality. I mean, you want people to live longer, and obesity is a huge hindrance in that goal. So
wow. Yeah. All right, the last thing, a lot of information out there. Yeah. Everybody's always on the internet, on the social media, and you hear things about take this medication, it's gonna cure your heart, put this oil on your head, and this is gonna be good. Talk to us about what we should be listening to out there in social media or in the media as a whole.
Yeah, I mean, it's interesting. Weekly I get my friends sending me stuff on Instagram or Twitter, with clips of, some new supplement or some new lifestyle thing that affects so-and-so percentage of, reduces your risk of so-and-so percentage of heart disease or whatever. And, people have so much access now to information, whether it's social media or just the copious amounts of, things we have to get this information and knowledge. And I think overall it's good. I like my patients to be informed. I think an informed patient and someone who's active in their care is more likely to, when they understand what they're being treated for and why they're doing it, they tend to be more compliant, and, they tend to really, I think, adhere better and just really be all in on their healthcare, which is important. It's also dangerous, right? I think, everyone has different motives, and I think what I caution all of my friends about when reading these headlines, and, really dig into, don't just read the headline and take it as face value. Try to look at the study. Part of our medical training is we learn how to dissect literature, dissect studies, and we know they're not all equal.
Right.
You can really, fabricate, or manipulate data to come out with an outcome you want it to show. So I tell my friends, listen, that's fine. It may be true that, this is an example. Being in a sauna could reduce, your cardiovascular mortality by 40. It's possible. I like the sauna. I'm not against it. It's an example. But look at the study. Was it 10 patients who are, wealthy CEOs, or is it a very generalizable study that, that randomizes people, and it can really be used. So the data is different. They're not all strong. So read the studies. Don't just take it for face value. But it's good. It's good to be informed, but just caution, don't take everything for face value.
And if you can't read the study, you can't understand, find a healthcare provider. Go to your primary physician, go to your cardiologist, and ask them, hey, doc, look at this study. This study says that, if I go into a sauna, I'm going to prevent heart disease. And you can explain to them, hey, that's only 10 patients. That is not a big study. These patients, so forth. So, just because it helped 10 people doesn't mean it's going to help everyone.
Awesome. Every week I get patients bringing in new things I've never read. So I learn stuff, and the back and forth dialogue, it's fun and it's important. I agree. I mean, that's part of our job too. It's not just, treating it. It's also answering questions. And we can learn a lot from our patients now, more than ever, I think. So absolutely ask if you have any questions about, what you're reading or what you find, ask a professional,
Thanks, Alex.
Of course, yeah.
Wow. So we've learned, I think the two things I've learned is prevention is most important.
Yes.
And then if you've had heart disease, there is care. There is treatment, there's care. Seek care, obviously, if you're having a chest pain, and you have your team of cardiologists at the hospital that will help. They'll do the medications or, God forbid, the interventions. But there is hope. But I think, an ounce of prevention is more important, I think, right?
Yeah, absolutely. Prevention is key. And, patients, luckily, cardiology is a field where it's constantly being innovated. We constantly have, better techniques, better procedures to treat something if it does happen, and people do very well. You listen to what your, provider says, and people have good outcomes, even if they happen to have a heart attack or heart failure. You listen to them, you'll do well. But yes, prevention's key. You want to prevent yourself from getting to that point. But if you do get to that point, don't be discouraged. I still have many patients to live great, long, healthy lives.
You get a second chance.
Absolutely.
Wow. Yeah. Well, thank you. Well, thank you once again from Miami Community Health. Dr. Anthony Gonzalez here with Dr. Alex Toirac here, wanting you to live longer. That's what we want. We just want you to live longer and live healthier. So on behalf of our team here from Miami Community Health, we